Recording in progress. Progress.
Hello, good evening, everybody. Are you able to hear? Hello.
Yes, sir.
Yeah. So today we'll be talking about applied neuroanatomy and EMG, and some questions will be asked initially. So let's see how many of you can answer to get going. When should an EMG be performed to assess for a lumbosacral radiculopathy? When an orthopedic physician consults you for one, when the diagnosis remains unclear after a proper history and physical imaging studies, if a patient has a herniated disc at L4-5 on magnetic resonance imaging, following a referral from the emergency department, they have an acute lifting injury producing pain in the lower back, numbness and tingling in the L5 distribution. So EMG is a specialized test done by the residents only. So you should know when you want to do EMG. Anybody can answer this? So before you warm up, let's see the answer.
B, sir.
Yes, when the diagnosis remains unclear after a proper history and physical imaging studies. So the electrodiagnostic studies, including EMG, are extensions of the history and physical examination and should be ordered when the diagnosis remains unclear. They help functionally assess the nerve, localize the lesion, and exclude other neurological causes. If you look at the electrophysiology lab, what you do in the lower limbs is only two nerves, posterior tibial and common peroneal. You may do sural nerve and superficial peroneal nerve. And these are things, but there are many nerves which are present, which are innervating the muscles, which we are not testing. The EMG is very helpful in that. Which of the following statements explains why snaps are usually normal in lumbosacral radiculopathies? Nerve root compression in a radiculopathy usually occurs proximal to the sensory dorsal root ganglion, DRG. The region of the nerve examined with the snap techniques assesses only the fibers distal to DRG that are still in contact with the healthy cell body. The question is why snaps are usually normal in lumbosacral radiculopathies. Nerve root compression in the radiculopathy usually occurs distal to the sensory DRG. The region of the nerve examined with the snap techniques assesses only the fibers distal to DRG that are still in contact with the healthy cell body. Nerve root compression is distal to the anterior horn cell of the spinal cord. Lumbar radiculopathies usually result in Wallerian degeneration of the sensory axon distally. What do you think is the correct answer? So B, that's right. Next. Yeah. So the nerve root compression in radiculopathy usually occurs proximal to the dorsal root ganglion. So preganglionic and postganglionic. The region of the nerve examined with the snap technique assesses only the fibers distal to the DRG are still in contact with the healthy cell body. So when you are doing nerve conduction studies in the lower limb, the snaps are elicitable. The lesion is preganglionic. If the snaps are absent, the lesion is distal to dorsal root ganglion. How many muscles should be sampled for EMG for a lumbosacral radiculopathy screen? 3 muscles plus 3 different areas of the paraspinal muscles, 5 limb muscles plus the paraspinal muscles, 8 limb muscles, paraspinal muscles are not sampled. B and C. See, you always plan to do a EMG whenever lumbosacral radiculopathy is asked for. You have to plan how many you are going to do. Somebody said, yeah. So it is the same applies for even brachial plexopathies and cervical radiculopathies. 8 limb muscles, if paraspinal muscles are not sampled, you have to test. 8 limb muscles, remember that 8 limb muscles are to be tested if you have to do. So these are some of the things which before others come. A screen of 6 muscles recommended if paraspinal muscles are included. Otherwise, 8 distal muscles are necessary. And in this, how you should select the muscles, we'll come to know. What is a typical clinical presentation of radiculopathy? Pain, paresthesias along the dermal distribution of the affected nerve root, visual disturbances, headaches, loss of consciousness. Very easy, and you don't have to. But the important point here is to know what are the dermatomes in the lower limb. Which is the dermatome that is on the medial aspect of the leg? What is the dermatome that is present on the medial aspect of the leg? What is the dermatome present in the interdigital?
L4.
Very good. Interdigital space on between toe and great toe and toe?
S1.
S5, L5,
L5.
L5. So you should know the dermatome. The question is framed only so that you'll remember all the dermatomes. Radiculopathies are usually, commonly present with pain, paresthesia, and dermatomes. So you should know what are the dermatomes in the upper limb, what are the dermatomes in the lower limb. You have to revise them. And if you put your hand on the back of the neck, what is the dermatome you feel? What is the dermatome when you put your hand on the back of the neck? What is the dermatome? When you put your hand on your shoulder, so go back and read, no, C3 and C4 and lateral aspect is C5. So the dermatomes are very important. In younger patients, what is the most common cause of radiculopathy? Is it degenerative changes of the disc, degenerative changes of the zygofacial joints, herniated disc, ligamentous structure change? What will be the most common for younger people? It's herniated disc. Younger people, it is a herniated disc, and older people, it is degenerative changes. So that is old age problem. And what is the most useful diagnostic tool in radiculopathy? Nerve conduction studies, F waves, H reflex, needle EMG. What is the most useful diagnostic tool? Out of all the four, what do you think is most important? Radiculopathies in the upper limb, C7 radiculopathy is the most common one. In the lower limb, L5S1 radiculopathy is more common. So, what is the most useful diagnostic tool on radiculopathy out of the four mentioned here? There's some answers. It's not A, it's needle EMG. EMG, that's why all the residents should be familiar with EMG, and I'll take another class on only on EMG. And for the time being, you consider needle EMG. Needle EMG is considered the most sensitive aspect of the electrodiagnostic examination of radiculopathy. What is the goal of electrodiagnosis in the setting of suspected lumbosacral radiculopathy? This we have already done. Sorry, it has come again. It is to confirm the root involvement and to localize the pathology to one or multiple root levels. I was telling you there are some root collateral nerves in the lower limb. Now, what are those root collateral nerves, and what do they supply in the lower limb of lumbosacral plexus? What are the root collateral nerves?
Superior gluteal and inferior gluteal.
And they supply what muscles?
L4, L5, S1.
Those are roots. I'm asking muscles.
Muscle.
And that muscle will cause abduction of
Gluteus
the
medius.
yes, extension of the thigh and abduction of the thigh. So these two movements are very important: abduction and extension. Gluteus medius and minimus. No, gluteus medius and gluteus maximus. Okay, these are the two important muscles, which extension and abduction. Right. Now, question: what is the typical finding of sensory nerve action potentials in lumbosacral radiculopathy? Increased amplitude, absent responses, normal, decreased latency. Somebody has quickly answered. What is the answer?
Normal.
Normal, that's correct. Somebody said C. Snaps are normal. I just mentioned distal dorsal root ganglion, preganglionic, and postganglion. Radiculopathies occurs proximal to the DR, the dorsal root ganglion. So snaps are normal. What does H reflex assess? Only the motor pathways, the sensory pathways, entire reflex arc, only the distal portion of the nerves. So H reflex is going to be a short answer question. What does it assess? Answer quickly. Yeah. What is the answer you said? Yeah. Right. Only motor pathways. No, it entire reflex arc. The entire reflex arc is assessed by the H reflex is a true motor monosynaptic spinal reflex. This is the entire reflex arc. It's useful for evaluating the S1 nerve root. When can the fibrillation potentials and positive sharp waves be observed in paraspinal muscles after axonal injury? Within 3 days, 1 to 2 weeks post-injury, 3 to 4 weeks post-injury, after 2 to 3 months. You are doing a paraspinal muscle.
3 to 4 weeks.
3 to 4 weeks, okay? So, fibrillation potentials and positive sharp waves typically appear in the paraspinals 1 to 2 weeks post-injury. They progress in a proximal to distal pattern. So you are correct, 3 to 4 weeks in distal. So in the proximally, they appear rarely in paraspinal muscle. The question is about paraspinal muscles. Now let's go to the upper limb. 44-year-old female presents to clinic with 3-week history of severe right shoulder pain, started without any antecedent trauma. Pain is beginning to improve, but she is now noticing significant paresthesias and weakness lifting her arm. On examination, some subtle winging of her right scapula, weakness of arm abduction, and external rotation. Needle EMG reveals fibrillations, positive shock waves, reduced recruitment in the serratus anterior, supraspinatus, and deltoid on the right with normal paraspinal muscles. Axillary compound muscle action potential amplitude also reduced significantly compared to the unaffected side. What is the most likely diagnosis? Radiculopathy based on significant limb muscle needle EMG findings, rotator cuff injury with secondary muscle trauma, and Parsonage-Turner syndrome based on the classic history. Unable to make diagnosis based on this information, MRI is needed. I think quickly people are answering that. That's okay. But why the winging of scapula? Why winging of scapula? What are the nerves that are coming from roots in the brachial plexus? Somebody can answer this. What are the nerves originating from the roots? Yeah, somebody has answered this. Lung thoracic nerve, dorsal scapular nerve. Okay, good. So these are the, what are the nerves that are coming from trunks? And what muscle in the brachial plexus? What are the nerves coming from the trunk? Correct. Suprascapular nerve, and that's correct. Nerve to subclavius is insignificant. It doesn't cause anything. So you remember these muscles because you may have to answer some of the questions that the combination of severe shoulder pain followed by weakness along with the specific muscles affected, that is serratus anterior, supraspinatus, and deltoid, the CMAP amplitude is the most consistent with the neuralgic amyotrophy. Class children. Which of the following statements regarding the true neurogenic thoracic outlet syndrome is true? It primarily affects the upper trunk or lateral cord. Abnormalities may be found in the ulnar sensory nerve action potential to fifth digit and the median and ulnar motor studies. It would be common to find fibrillations and positive shock waves in the biceps and deltoid. Rarely do physical examination findings correlate with the electrodiagnostic findings. What is the answer? Thoracic outlet. B. So abnormalities are usually, CAT1 and medial cord, lower trunk, medial cord, and ulnar nerve. All these will have same findings. Ulnar sensory nerve action, fifth digit, median ulnar motor studies, you will have abnormalities. They are found. So CAT1, lower trunk, medial cord, and ulnar nerve will have same findings. Right. Neurogenic thoracic outlet syndrome typically affects the lower trunk, resulting in CAT1 weakness, thinner wasting, and paresthesias in the medial arm, forearm, and hand. This will lead to abnormalities in the ulnar and medial antebrachial cutaneous nerves and median and ulnar motor studies. Fibrillations in the biceps and deltoid would be more consistent with the more proximal lesions of the brachial plexus. So that is not a correct answer. So examination of the medial aspect of the arm is very important, sensory examination. If you have sensory loss in the medial aspect of the forearm, that means it's not in the ulnar nerve, it's beyond ulnar nerve. That's the catch point which you should know. 65-year-old female with a history of breast cancer with multiple treatments of radiation to her axillary nodes now presents with increasing paresthesias in the right upper limb and weakness in CAT1 and lateral cord distribution without significant pain. Electrodiagnostic findings are consistent with lateral cord involvement with myokemia seen in needle EMG. Which of the following statements is correct? The lack of significant pain is more consistent with a secondary neoplastic process. Presence of myokemia and lateral cord involvement is most consistent with the radiation-induced cause. Lack of complex repetitive discharges makes radiation-induced plexopathy unlikely. Electrodiagnosis is of no value in this case. Somebody has answered this question. B. The lack of significant pain is more consistent with the secondary neoplasm is wrong because neoplastic processes always cause pain. So second answer is the answer, the presence of myokemia. Radiation-induced neuroplexopathies tend to be painless, often affecting the lateral cord and can show myokemia on needle EMG. The involvement of the lateral cord, presence of myokemia are consistent with radiation injury. We have got only a few more questions. A 20-year-old male soldier presents weakness of the left upper limb without significant pain shortly after carrying about 80 lb rucksack while deployed overseas. Denies any significant pain in the limb or shoulder. Which of the following statements is true? X-ray should be obtained to evaluate for the presence of a cervical rib. Electrodiagnostic studies will show evidence of a demyelinating conduction block. This pathological process is most likely due to an underlying autoimmune disorder, likely an injury to the isolated peripheral nerve branch of the brachial plexus. What could be the cause for this? This is a common occurrence, though we have brought in a soldier here, but we can keep seeing this. What's the possible cause? Yeah. D. No. See, this is a conduction block because of demyelination. Electrodiagnostics will show evidence of demyelinating conduction block. Rucksack paralysis typically associated with a demyelinating conduction block. The sensory nerve conduction studies are often normal, while the motor nerve conduction shows a conduction block. A decreased recruitment pattern on needle EMG is also expected. Patient with suspected lower trunk brachial plexopathy may present with one of the following: winging of the scapula, Horner syndrome, severe shoulder pain, muscle spasms. Horner syndrome. That's good. Very nice. Okay. Four more questions. Right. We are following the common anatomic variant of a brachial plexus. Long thoracic nerve originates on lower trunk. Martin-Gruber anastomosis. Suprascapular nerve originates from the T1. Median nerve is found by the lateral root and two medial roots. Somebody has already answered this. What is Martin-Gruber? Martin-Gruber anastomosis is a exam question.
Median ulnar anastomosis.
How many types are there? Okay, if the snap amplitude, we'll see today's class. We'll read about the anomalies in the upper limbs. Not only median to ulnar, the various varieties are there. There are three types of MG. If the snap amplitude on affected side is less than what percentage of the unaffected side is considered abnormal? 75, 60, 50, 25%. You are doing snaps of both. Yeah, 50% is correct answer. Right. Last question. Which of the following is not typically associated with a supraclavicular injury? Rucksack, Burner syndrome, postoperative paralysis, and crutch palsy. Yeah, that's correct. I think many people have answered this. D is correct. Crutch palsy is because of lower trunk. The Burner syndrome is seen in the basketball players, postoperative paralysis, rucksack. These are all upper limb, upper block, brachial plexus. So with this, we'll come to the basics of neuroelectrophysiology for some time before we go on to the upper limb, right? So some are beginners in this. The process in which intracellular potential travels to the extracellular tissues is termed volume conduction. Very important to understand this concept. The compound muscle action potentials and sensory nerve action potentials result from extracellular recording of what is happening in intracellularly. So understand this volume conduction. This occurs as the impulse travels from the stimulator which you are applying through the extracellular tissue to the stimulated nerve. The stimulator produces a potential which travels down the nerve to the muscle in which the action potential is generated, that is picked up by the electrodes placed over the muscle belly. Now, the essential for nerve conduction studies is the volume conduction. Excessive volume conduction produces inaccurate waveforms. If high intensity stimulus is applied, excess volume conduction occurs, multiple nerves will be stimulated and a composite erroneous waveform results. So you have to be very careful in applying the amount of electricity that you are stimulating the nerve. You got near fields and far fields. What is a near field potential? A volume conducted potential that is recorded close to its source is termed a near field potential. Compound muscle action potentials, sensory nerve action potentials, and motor unit action potentials are all near field potentials. Far field, as the recording device is moved away from the source, the amplitude is decreased and latency is prolonged. By definition, far field potentials do not change significantly in latency or amplitude with distance from the source. That is, somatosensory evoked potentials, visual evoked potentials, brainstem auditory evoked responses, these are all far field potentials. So volume conduction, you see, ulnar motor supramaximal stimulation results in excitation of only the ulnar nerve. So you have to increase the current as you see the waveform. And if you increase slightly above that 10 to 15 microvolts, then it should not increase. So this is a normal morphology of CMAP and normal onset latency. You can see the morphology of the median nerve and median motor, higher supramaximal. What happens if you increase the current? What will happen? It goes significantly altered CMAP morphology with a long duration. Here, the supramaximal stimulation results in co-stimulation of the ulnar nerve also. So you get this type of picture. So briefly, the dorsal root ganglion, dorsal ramus, and ventral root, the spinal nerve, ventral ramus. So this particular anatomy is often asked in question people forget. The why we do paraspinal EMG is to test the paraspinal muscles, and that is the posterior rami are supplying that. If paraspinal muscles are involved or not involved, you have to see. Radiculopathies, they are involved. And so these are the one question we got, that's lateral L4-5 disc herniation, and F wave prolongation is seen, and EMG is important to study this lumbosacral plexopathies, discs, and cervical root C5, C6. You can see the disc and which will press the nerve. You can see that, and this is the cervical vertebral body, and this is the C6 nerve root. You can see the next. So let us see what are the muscles. Brachioradialis, extensor indicis proprius, gluteus medius, semitendinosus, short head of biceps, long head of biceps, and you identify various nerves and their peripheral nerves. These are the muscles, these are nerves, and these are roots. Now, why we should know, we know is that we have to select different roots, same nerve, different root, and same root, different nerves. So we have to understand the root values of various nerves, and these are the important ones which mentioned here for radial C5, C6, and extensor indicis pollicis is C7, C8, gluteus medius, that is L5S1, and we already said that is the superior gluteal nerve. Semimembranosus, semitendinosus. These are some of the important things which we'll talk. So you have to have a list of all the muscles you are going to do. In the upper limb, what are the EMG muscles? In the lower limb, what are the EMG muscles you're going to do mostly? And you start with first dorsal interosseous, CAT1, abductor pollicis brevis, CAT1. This is a median nerve supply, but the root value is CA. Actually, APB is T1. Pronator teres is C6, C7 median nerve. The median nerve, which is doing the pronator teres, C6, C7 roots, triceps radial, biceps musculocutaneous, deltoid axillary. So there are different nerves here, axillary and musculocutaneous, but the roots are same. Similarly, the roots are same here, C6 and C7. C7 root you can see pronator teres and triceps. So when you select for EMG, we have to understand the root values and the nerves which we commonly. So flexor compartment of the forearm, the flexor carpi ulnaris, and medial half of the flexor digitorum profundus. So except this, the median muscles are all of them. Median muscles are all. Loaf muscles, two lateral lumbricals, opponens pollicis, abductor pollicis brevis, flexor pollicis brevis, superficial head. These are all median muscles. So there is a nerve called anterior interosseous nerve. Anterior interosseous nerve supplies flexor pollicis longus, pronator quadratus, and flexor digitorum profundus 1 and 2. So that's another anterior interosseous nerve supply. So ulnar muscles, flexor carpi ulnaris, and medial half of the flexor digitorum profundus. All the intrinsic muscles except the loaf muscles, two loaf muscles. And hypothenar, all supplied by ulnar. Thenar, adductor pollicis, two interosseous and medial lumbrical. So you have to remember all these, the pad, dab, all the muscles that are in the, which we are going to examine. The radial muscles are triceps, anconeus, brachioradialis, carpi longus, brevis, ulnaris, supinator. And there are three muscles going to thumb: abductor pollicis longus, extensor pollicis longus, extensor pollicis brevis. Two to the fingers, so digitorum communis and indices, one to extensor digiti minimi. So the thumb is unique in that it will be supplied by all the three muscles, and integrity of the thumb indicates that all both radial, ulnar, and median nerves are intact. So examination of thumb is very important. And one of the important branches is the palmar cutaneous nerve, which supplies the sensation of the lateral palm of the hand, which peels off before carpal tunnel. So it is spared in carpal tunnel syndrome. And digital branches are supplied after the carpal tunnel, supply sensation to the palmar aspect of the tips of the lateral 3.5 fingers. So if you're asked what is the point with which you will examine the median nerve, that is the tip of the index finger. That is the median nerve. Ulnar nerve is the little finger, and radial nerve is the anatomical snuff box. These are the areas which are dedicated to the individual nerves in the upper limb. So you can see the lower limb nerves. We'll take later, so we'll skip that. Right. So the cutaneous supply, which we were just mentioning, the distal median, superficial radial, palmar cutaneous. So important point, which I mentioned earlier, the medial aspect of the forearm is supplied by CAT1. If there is a sensory loss only on the medial aspect of the little finger and the palm, it's ulnar nerve. If the sensory loss extends the medial aspect of the forearm, then it is no more ulnar nerve, it is C8, T1, T1 distribution sensory loss. So these are the branches which we usually do a sensory testing. Then we'll go on to the basic EMG techniques and what we do in EMG and with the needle EMG. EMG is a specific electrodiagnostic technique in which an electrode is used to visually and sonically display the electrical activity of the muscle. A needle electrode is inserted through the skin into the specific muscles to acquire and display muscular electrical activity as a waveform. It's a tool to measure the electrical activity in the muscle. No electrical stimulation is used with EMG. It evaluates each of the four basic components of standard EMG: insertional activity, spontaneous activity, motor unit analysis, and recruitment for each muscle which you're going to sample. So there are some checklists where confirm the patient's identification, verify the identification for the EMG, a brief overview of the test, and reassure the patient about minimizing the discomfort. There will be pain. Ask about possible contraindications of precautions such as anticoagulant use in cases of stroke. We are doing do it. Verify the ground and reference electrodes are in place. The muscle being examined should be relaxed and accessible to the examiner. Gloves should be observed. Avoid examining areas of skin compromised, such as open wounds, skin infections, significant areas of edema, and lymphedema. It's not good to do EMG. And on the machine, you confirm the gain, sweep speed, filter settings are appropriate. Verify the ground and reference electrodes are plugged in. Make sure that preamplifier is turned on. The needle serves as an active electrode. When a monopolar needle electrode is being used, a reference electrode is necessary. The reference should be nearer the location of the needle insertion. A concentric needle we don't usually use. A separate reference electrode is not necessary. So reduce the anxiety and discomfort associated with the EMG. Pain is a common if the needle is in the muscle end plate region. When this is apparent from the presence of end plate noise or spikes, quickly reposition the needle away from that area. You make the skin taut and enter the needle. As soon as you enter, there will be some electrical disturbance and would settle down in a second. If it doesn't settle down and there is pain, that means the needle is near the end plate. That's called end plate potential. You have to provide discomfort and verbal sympathy with the patient throughout the study. Reassure the patient that any discomfort associated with EMG is not long lasting. Insert a needle through the skin quickly, but move the needle within the muscle gently and slowly. See, if you delay insertion into the skin, that is more painful. Inside the muscle, that's not painful at all. You can move slowly, there's no problem. But when you insert into the muscle, it should be fast. Avoid hyperventilation. Change needles if there is increased resistance or excessive pain associated with the needle in movement. Then the anxious patients begin with the most important muscle to minimize the number of needle insertions. Paraspinal muscles in suspected radiculopathy do first. Warm the patient. Then some muscles, hand muscles or foot muscles, may be more sensitive than others. Reassure the patient that he or she can choose to discontinue the test at any time. Stop that. Don't prolong. You may have a cardiac arrhythmia on your hand if you continue. Find the muscle belly by using the surface landmarks. So surface anatomy is very important. Confirm the position of the muscle belly itself. To do this, palpate the muscle belly and ask the patient to activate the muscle. The examiner should feel the muscle contraction. Clean the area with alcohol swab. Warm the patient before each new needle insertion. Retract the skin, making it taut, which will help the needle enter more easily. One quick motion, insert the needle tip through the skin into the subcutaneous tissue. Going slowly or softly increases the discomfort. So decide I want to do this, inject, put. Using concentrated, keeping the bevel upside up during insertion will minimize discomfort. Always, if you have a bevel, you should keep it up. Advance the needle through subcutaneous tissue until the needle enters the muscle. Once in the muscle tissue, ask the patient to slightly activate the muscle to confirm the proper placement. You can hear a EMG signal. You provide sufficient resistance to ensure a gentle isometric contraction. If the needle is correctly placed, electrical activity will be seen on the screen and heard. So before you start EMG, ask him to do 3 maneuvers: normal, mild contraction, and a bit forceful contraction. Why do we do EMG? EMG we do to insertional activity, spontaneous activity, whether it is normal, abnormal, and the muscle during activation, mild effort, moderate effort, and full effort. All the 3 we have to test. The insertional activity, the electric activity caused by the insertion or movement of a needle electrode within a muscle. That is what you see on the screen because you moved the needle. As I said, you have to check in 4 quadrants for insertional activity. which is increased in case of inflammatory myopathies. So increased insertional activity is an abnormal finding. Electric activity recorded from a muscle with consciously controlled contraction is voluntary activity. And in contrast, you got a spontaneous activity. The electric activity that is recorded from a muscle at rest after the insertion activity has subsided, and when there is no voluntary activity, the individual should be asked to totally relax. There should be no activity at all. The needle is not moving, the patient is completely relaxed. If you are seeing some electrical activity, that is called spontaneous activity. Noise from the nearby equipment, pacemaker spikes, loose electrodes, faulty wires, ringing cell phones, and so on will cause artifacts. So this, you see the motor unit. How the motor unit is located, you can see the motor unit. See, these are the motor axon, the branches of motor axon. These are the myofibrils. You can see the axons are homing on to different types of muscle fibers in the motor unit. This is a motor unit anatomy. Nerve conductions are limited to CA-T1 in the upper limb, L5S1 in the lower limb. So that's not sufficient. You have to choose different muscles to determine a root level. Same root level, different nerves. The paraspinal muscle involvement is present or not also, you have to examine. So these are the important issues. Compressive entrapment nerve lesions, choose different muscles to determine a nerve involvement. So same nerve, but different roots. Determine whether lesion is affecting myelin, that is demyelinating, or axonal, or both. So FIPS and polys or long duration that suggests that weakness, the insult has happened more than 3 weeks. Polyphasia within 2 months. Long duration usually within 8 months. So the timing of the insult can be gauged, which I will explain in further slides. So let's look at the insertional activity. It starts as you insert a needle into the muscle. You should stop and become flat line when you stop the insertion. As soon as you put the needle, there will be some activity and which subsides. End plate potential is encountered when the needle is near the nerve entry into the muscle. It sounds like a seashell noise. It will not stop unless the needle is removed, and it can be painful too. So that's important. You have to differentiate from insertional activity. It's abnormal insertional activity, fibrillation potentials, and short waves. So these are usually seen in early denervation, typically 3 weeks after lesion, FIPS and positive shock waves, which you can see FIPS, and this one is the positive shock wave, and this is the FIPS. It's not painful, does not stop if you pull the needle away from it, and fires regularly. So MUAP, when you do, you have to look at amplitude, duration, and phases. We'll describe why these differences will come in this. So what are the 3 things, what the motor unit action potential, what we see usually? The needle EMG picks up MUAP. The amplitude is determined by 2 to 3 fibers which are nearer to the needle tip, whereas the duration is due to all the muscle fibers which are present. So the muscle fibers in the so that's the difference. Why the duration and the amplitude different. So when you put a needle on that needle tip, will pick up the electric activity from 2 to 3 fibers only, whereas the duration is dependent on all the muscle fibers of the motor unit. So that's the duration from here to here, and these are the phases, and more than 5 phases are abnormal. These are turns around the baseline. So this MUAP analysis is very important for you to understand. And neurogenic EMG means there's a grouping of these sprouting neurons occurs, and they give rise to various types of abnormal joint action potentials and the complex repetitive discharges. Normally, MUAP is seen after activating the muscle, typically 1 to 3 phases only. Number of units goes up as effort is increased. So this is the normal motor units. It needs to be observed at mild, moderate, and full voluntary effort. That's what I was telling. Slowly, more and more. Seen in chronic nerve injury that is abnormal, typically 4 to 5 phases, long duration and polyphasia. It sounds thundery on screen. More recent nerve injury shows polyphasia. Old injury, long duration MUAP. The duration, if increases, it's long duration. Polyphasia, more recent nerve injuries. So you have to evaluate insertional and spontaneous activity by using 4-quadrant technique. In each quadrant, do the following. Advance the needle 5 times in a straight line. Each of these advancements should be small, 1 millimeter or less, to minimize the patient discomfort. Between each advancement, wait 1 to 2 seconds and listen for insertional and spontaneous activity. Once 5 locations in the quadrant have been evaluated, slowly retract the needle until it is out of the muzzle but remains in the subcutaneous tissue. Adjust the needle position and examine the next quadrant. So 4-quadrant technique is what is used, but usually we don't do, but ideally we have to do this 4-quadrant technique, and each quadrant we have to advance the needle 5 times in a straight line. Each of these advancements should be small, 1 mm or less, to minimize the patient discomfort. So once you advance, you wait for 1 or 2 seconds and listen for the insertional activity and then move on. So with the insertion of the needle and in the subcutaneous tissues, ask the patient to minimally activate the muscle that is being tested and provide some resistance sufficient to ensure isometric contraction. To contract more or less to identify a predominant individual motor unit to properly assess the motor unit recruitment. See, MUAP is best heard than seen. The sound should be very clear. And you should get used to that sound, and you should be preferring to see how sharply you are getting the sounds. Advance the needle into the muzzle and adjust the needle to best analyze the individual motor unit potential. Ask the patient to maximally activate the muscle being tested, provide resistance sufficient to ensure an isometric contraction. The maximal intensity muscle contraction with a needle inserted can be very uncomfortable for the patient, so should be used sparingly. So whenever you do the interference pattern, it is either early recruitment, incomplete, or complete. So after each muscle is examined, remove the needle and apply local pressure with the sterile gauze to achieve hemostasis. After examine, clean the area if necessary. The patient frequently how she is doing. Adjust your technique as necessary. Just don't go on doing without caring for what the individual is feeling. At completion of the study, dispose of the needle in a sharp container when finished. Reassure the patient about his cooperation, sympathize with any discomfort, the bleeding and all things to be taken care of. So that's how the needle EMG is done. The 5-quadrant method, you are inserting the needle 1 second, and you have to in 4 quadrants, you have to 5 times you have to enter 1 mm, 1 mm, 1 mm like that. And isometric muscle contract, you can see the hand being contracted when the EMG is being done in the extensor group of muscles. So motor unit action potential, the summated electrical activity of muscle fibers that is innervated by a single axon, it only reflects those fibers within the range of the needle electrode. As I said earlier, amplitude usually reflects no more than 10 muscle fibers in the vicinity of the electrode, while all of the muscle fibers belonging to the motor unit contribute to the duration. Usually that is triphasic. The duration is more number of muscle fibers, whereas amplitude is only couple of fibers which are nearby. Amplitude first observed MUP is 300 to 500 microvolts. Later recruited MUP is up to 3 millivolts. So giant refers to more than 5 millivolts. Duration normally is 5 to 15 milliseconds. Frequently, typically starts 3 to 5 hertz and increases with effort up to 30 hertz, not regular but semi-rhythmic. Polyphasic motor unit action potentials, 5 or more phases, up to 20 to 25% of recorded MU pace may be polyphasic in normal persons, depending on the needle positioning. When pathology can be caused by collateral sprouting, seen with the denervation, or drop off of muscle fibers, seen with myopathy. So in neuropathies, it is collateral sprouting. In myopathies, it is dropout. So these are the types of voluntary activity which we do in the EMG. And what are the discharges which we should know? Fasciculation potentials. Same configuration as a single MUAP. Sporadic, whereas grouped sounds like a bird dropping against the windshield of a fast moving car. Whack. So single random spontaneous twitch due to hyper irritation somewhere along the neuron, which activates all or significant number of muscle fibers belonging to a single motor unit. Very often it can be normal, can also be grouped in pairs or triplets, fasciculation potentials. Myochemic discharges are grouped fasciculations. Same configuration as MUV, but two distinct firing patterns are seen. One is a brief uniform repetitive firing of motor unit action potential at 40 to 60 hertz for up to a few seconds with brief period of interposed silence. Sounds like bursts of machine gun fire or the drum solo from One by One, no, Metallica. Continuous recurrent uniform slower firing also can be seen like a marching soldiers. So the myochemic discharges originate somewhere along the motor neuron. Irregular discharge of motor unit possibly with ephaptic transmission, sometimes seen with demyelinating conditions. So these are then as you go on doing, you can observe all these things. Neuromyotonic discharges, cramp potentials, you read by yourself, and I'm not going to elaborate on them. So let's go to the spontaneous electrical activity, which is very important, and miniature end plate potentials or end plate noise. It is very small, 10 to 50 microvolts. Duration also 0.5 to 2 milliseconds. Approximately every 5 seconds per axon terminal, but clinically multiply observed at once. Irregular rhythm, negative initial deflection that is going up, and monophasic seashell murmur. It's random, spontaneously released acetylcholine vesicles from the nerve terminal, and they cause this, and there will be pain for the muscle end potentials. The miniature end potential cause pain. So end plates also you have to differentiate, which are about 300 microvolts, 2 to 4 milliseconds, 50 to 100 hertz. Biphasic with initial negative deflections. That means negative deflection means it going up. And sputtering fat in the frying pan type sound. It is irritation by the needle electrode to the terminal axon, which results in the suprathreshold end plate depolarization of a single muscle fiber. The fibrillation potentials and positive sharp waves. And now you have to remember this and identify them definitely. Less than 1 millivolt. And their duration is less than 5 milliseconds. Usually slow but wide range, can be 1 to 50 hertz. Often decreases just before cessation. They are usually regular. Biphasic with initial positive deflection. Positive means going down. Rain on a rooftop. So ticking positive shock waves, dull thud. Fibs are generated by one single physiologically unstable sacrolemma. The resting membrane potential slowly creeps upward until threshold is reached. A spontaneous depolarization occurs, followed by repolarization, with the cycle beginning over again. Whereas positive shock waves are thought to be a variation of the fibrillation, except that the muscle fiber at the recording site is deformed by the presence of the needle electrodes. So the two different pathophysiology of these two. The unstable resting membrane potential leading to fibrin potentials and positive shock waves can occur from direct muscle injury like trauma, inflammation, or denervation. So both in myopathies and neuropathies, you can encounter both these activities. And complex repetitive discharges, bizarre repetitive discharges, pseudomyotonia less than 1 millivolt, variable but start, stop, abrupt, 3 to 150 hertz, regular rhythm, may display abrupt changes in configuration, machinery sound, what happens here is a group of single muscle fibers spontaneously depolarize in a set pattern, which is directed by a primary pacemaker fiber. Usually seen in chronic processes where a group of muscle fibers become unstable, similar to those we have seen in FIPS and positive sharp waves in denervation or myopathy, may also be normally seen in iliopsoas muscle. Monotonic discharges and 10 microvolts to 1 millivolt, more than 5 to 20 milliseconds, 20 to 100 hertz, waxing and waning, amplitude and frequency, and dive bomber, intermittently accelerated and like a idling on motorcycle, rapid, repetitive, variable, waxing, waning amplitude, frequent firing of FIPS or positive sharp waves appearing potentials. The primary defect is in the membrane ionic conduction. Character requires needle movement or muscle contraction to elicit this. So you can grade them, the positive sharp waves and fibrillation potentials, into none, 0. Fibrillation potentials persist in at least 2 areas is 1. Moderate number of persistent fibrillation potentials in 3 or more areas, 2. Large number of persistent discharges in all areas, 3. Profuse, widespread, persistent discharges that fill the baseline in 4. So these are how you grade them. This is the fibrillation potential, which is you can see. And these are the end plate spikes, which you can encounter. And these are the positive sharp waves for recognition. You have to remember this. And complex repetitive discharges, which are depicted here. So the MUAP analysis, a motor unit consists of a single motor neuron and all the muscle fibers it innervates. The number of muscle fibers innervated per motor unit neuron is referred to as the innervation ratio. This ratio varies depending on the muscle size. Muscles that are used for precise movements generally have smaller innervation ratios. MUP is an EMG response that results from the discharge of all the muscle fibers that are innervated by a single motor neuron. And an MUP represents summation potential of all the muscle fiber action potentials that are elicited by their common motor neuron and are close enough to the tip of the recording electrode to be able to register. The MUP amplitude is dependent on only a couple of muscle fibers which are nearby. The size and shape of MAPs are dependent on the size, number, and functional state of the muscle fibers that are innervated by a single motor neuron in the region of the recording electrode. Described in terms of amplitude, duration, phases, stability, which we have already seen. Healthy state, MUAP is stable due to all or none nature of the action potentials, as well as the reliability of neuromuscular transmission, that is a safety factor. Whereas in denervation, dysfunction of the neuromuscular junction and altered excitability of the muscle fibers may cause MUAPs to become unstable, having variable sizes and shapes between consecutive discharges. The firing characteristics and the recruitment of motor units can also be quantified, enabling identification of different patterns of pathology of neuromuscular system. So we can see the recruitment ratios and other things which you can calculate. So this MUAP is then the morphology. The duration of MUAP is the total amount of the time of the recorded potential is measured from the initial deflection from the baseline potential until the final return to the baseline potential. It correlates with the number of muscle fibers that are innervated by a single motor neuron in the region of the electrode. During processes of the muscle fiber degeneration or in inexcitability, the MUAP duration will be shortened. The myopathies is a short. During process of denervation, collateral spouting occurs and reinnervation happens. Increased numbers of muscle fibers will be innervated by a single motor neuron in the region of the electrode, leading to an increased MUAP duration. So MUAP durations are usually between 5 and 15 milliseconds, as I mentioned earlier. The amplitude is generally measured from the maximal negative peak to the maximal positive peak, and the peak to peak. Amplitude of MUAP reflects the number of muscle fibers innervated with single motor neuron in the region of the recording electrode. So Amplitude is also influenced by the size of the individual muscle fiber closest to the recording electrode. Therefore, amplitude is less well correlated with the number of muscle fibers innervated by motor neuron. Related to electrode type, if the electrode is usually the amplitude is about 100 microvolts to 2 millivolts, upper limit of 6 millivolts is generally used for a monopolar electrode and 4 for the concentric electrode to declare it's a giant MUAP. So these are the amplitude, these are the phases, the turns, the duration, which you have to analyze. The term phase is used to describe the individual components of a motor unit action potential that are above and below the baseline. The number of phases can be calculated by taking the number of baseline crossings and adding 1. The term turn describes a change in amplitude of the MUAP that does not cross the baseline. Most MUAPs will have between 2 and 4 phases. Greater than 4 phases are referred to as having polyphasic. It is the polyphasia is a result of desynchronization of the summation of the muscle fibers that contribute to the MUAP. Desynchronization can occur due to early reinnervation as well as degeneration and regeneration of muscle fibers. The polyphasic MUAPs are non-specific, and healthy muscles also may be at times show polyphasia. Summated potential, action potentials within the recording area is what MUAP is. In healthy state, there is stability of the MUAPs at the neuromuscular junction, and the size and shape may vary at times in healthy patient also. Most likely is related to the movement of either needle electrodes or the muscle. In pathologically abnormal neuromuscular junction transmission, abnormal excitability of the muscle fibers can result in a variable MUAP size and shape. So let us look at the disease MUAPs. What happens in myopathies? Short duration, small amplitude, polyphasic MUAPs are characteristic of myopathic process. A variety of myopathic processes can result in disruption of muscle fiber action potential generation. Some of these may include immune cell invasion of the muscle fibers like inflammatory myopathies, such as dermatomyositis, immune processes, necrosis of muscle fibers, toxic inexcitability like periodic paralysis, loss of muscle fiber integrity function that may result in loss of muscle fiber generation, action potential generation. So inflammatory myopathies are very important and for our day-to-day practice. Loss of muscle fibers and that is leading to loss of action potentials that results in the reduced size of the summated MUAP amplitude, and EMG reflects all these changes. In the cases of very chronic myopathies, characterized by cycles of regeneration, degeneration of muscle fibers, milder forms of muscular dystrophy, inclusion body myositis, the myopathies become complex and polyphasic in appearance. Long duration means long duration, polyphasia. Duration is increase of myopathies means long duration. The amplitude are generally reduced in myopathies because of a reduced number of muscle fibers or reduced excitability of muscle fibers. The chronic myopathies can display muscle fiber hypertrophy, which in turn can lead to MUAPs with increased amplitude. So there may be a discretion which you have to observe, whether it is neurogenic or myopathic. Increased MUAP amplitude in myopathic conditions usually reflects muscle fiber hypertrophy rather than grouped innervation, like happens in neuropathies. So long duration, large amplitude, polyphasic MUAPs are characteristic of neuropathic. At the end of the EMG, you will record either it is a neuropathic process or a myopathic process. That's all. EMG will show you that much. Denervation leads to reduction in the number of motor units that are functionally connected to a particular muscle. In the acute setting, that is up to 8 weeks, does not usually result in immediate changes in MUAP size or shape. The denervated muscle fibers can be reinnervated through mechanism of either collateral sprouting or axonal degeneration or regeneration. This sprouting occurs when denervation is partial or incomplete. The terminal axons of the motor units that are intact sprout to reconnect to the denervated muscle fibers. That's why you get giant action potentials. So if you Following this collateral reinnervation, single motor neuron will have an increased number of muscle fibers it innervates, and the resulting MUAP will be increased in size, both amplitude and duration, what we call fasciculation potential, Jain fasciculation potential. As it takes time for these new axon, collateral sprouts, and neuromuscular junctions to mature, MUAPs during the early stages of reinnervation will have increased polyphasia. So MUP changes in collateral sprouting are usually noted approximately 8 weeks following partial denervation. In contrast to collateral sprouting, axonal regeneration is a delayed phenomenon, dependent on axonal regrowth from the site of nerve injury towards the denervated targeted muscles. So axonopathies usually have compound muscle action potentials, which are nerve condition steady reflection, which have low amplitudes. So let's look at the diseases and some of the interesting things which we can concentrate. In axonal regeneration, the first synaptic connections are made with a denervated muscle will be with only a few muscle fibers, the MUAPs of reduced size. These early, small, immature MUAPs that result from axonal regeneration are sometimes referred to as nascent MUAPs. Over time, these new nascent MUAPs can become larger in amplitude and duration as and when more muscle fibers are reinnervated. So in contrast to the collateral sprouting, which is really evident within the approximate 8 weeks, the efficacy and timing of axonal regeneration is dependent on the distance of the target muscle from the site of the nerve injury. The longer distance the target muscle is and the site of injury result in longer duration prior to reinnervation as well as less effective reinnervation. So that brings us to the recruitment pattern. Motor unit recruitment refers to the sequential activation of the motor units during an increasing muscle contraction. It is one of the main aspects of the motor unit action potential analysis during the EMG. The recruitment can be used to distinguish normal versus underlying myopathic or neuropathic conditions. So you have to look at the sweep speed of 10 milliseconds per division. The time period contained on one screen is about 10 boxes into 10 milliseconds. That means 100 milliseconds per screen. And a screens as 1 second is equal to 1000 milliseconds. And 1000 milliseconds to 100 milliseconds, the 10 screens per second. 10 screens per second. The sweep speed of 20 milliseconds per division means 5 screens per second. So 1 second is equal to 1000 milliseconds. So this much knowledge is required to interpret your MUAPs. So you have to calculate the firing rate, determine how many screens there are in 1 second, count how many of these same motor units are on the screen, multiply them together. Let's example. Calculate the firing rate of the fastest MUAP, where the sweep speed is set to 10 milliseconds per division and 2 motor units are noted in the screen. So look at 10 boxes per screen. What you are saying into 10 milliseconds per box is 100 milliseconds per screen. And 1000 milliseconds per second divided by 100 milliseconds per screen is equal to 10 screens are there in 1 second. So 2 motor units are per screen into 10 is equal to 20 is the firing rate. You can calculate the recruitment ratio also. Contract muscle with minimal to moderate force and generate the MUAPs. Calculate the firing rate of the fastest MUAP. Count the total number of discrete motor unit potential screen on screen. Divide the firing rate by total number of discrete motor unit potential. Let's see how it is. Use the previously calculated firing rate, calculated the recruitment ratio of the motor unit where there are 4 distinct motor units noted on the screen. Firing rate, number of different motor units on the screen, 20 by 4 is equal to recruitment ratio is 5:1. So the motor unit recruitment can be normal early in myopathic, decreased in neuropathic. As you can see, there is normal and there is a myopathic and this is the neuropathic. The normal recruitment of 3 MUAPs during concentric needle electromyography of a muscle during a gradually increasing contraction. So you can see one usually increase and more motor units are getting recruited here. So During muscle contraction, what happens is the force output is modulated by the number of motor units recruited and the rate of motor unit discharge. Under voluntary control, motor neurons and motor units fire semi-rhythmically, no slower than 4 to 5 hertz. So during normal contractions, the maximal motor unit firing rates are usually less than 50 hertz. During ballistic contractions, the firing rates of motor units may reach over 100. So according to the size principle, during the gradually increasing muscle contractions, smaller motor units innervating type 1 muscle fibers are recruited first, followed by large motor units innervating type 2 muscle fibers. Last class also, we were mentioning about this. So what are the basics of the analysis which you have to do in the recruitment? So what recruitment is particularly helpful in identifying disorders of peripheral nervous system. Simply stated, recruitment is assessed by determining whether the MUP is activated during a muscle contraction or firing at appropriate rates. MUP recruitment is best evaluated at minimal to moderate levels of muscle contraction to allow discernment of individual MUPs. The recruitment patterns can be described as normal, early, or late. Recruitments can be classified, quantified during recruitment ratio as we have calculated just now. So analysis of recruitment is very, very important. Myopathic conditions result in early recruitment with increased numbers of motor units recruited than would be explained for force produced during a muscle contraction, whereas neuropathic things is the other way. Recruitment is not altered in upper motor neuron pathology. In UMN disorders, insufficient patient effort or activation of motor units may be reduced, resulting in a reduced number of motor units firing at lower frequencies. So that's the important part of the recruitment analysis. So stepwise assessment. Confirm that the gain and sweep speed settings are appropriate to fully view the MUAPs and to allow recruitment quantification. Sensitivity setting will depend on the size of the MUAPs and should be set to allow full visualization of the MUAP on the screen. The sweep speed is somewhat dependent on personal preference, that is, but is usually set to 100 or 200 milliseconds. Based on the differential diagnosis, determine the muscles to be tested. The patient in a position that facilitates isometric contraction, have patient perform a minimal or moderate contraction to allow the visualization of the MUAPs. So that's how we do the MUAP analysis. And so because we have already the myopathic process and neuropathic process, we have already said number of times. Again, just say the neuropathic process, loss of MUAPs may be the result of either conduction block or axonal loss. The remaining MUAPs that are remaining, the recruited during a muscle contraction will be firing at a higher than expected rate. In the case of chronic axonal nerve injury, recruitment may be normalized if motor units are able to re-establish the sprouting, collateral sprouting happens. The collateral sprouting will not correct reduced or late recruitment following the axonal injury, but more it may be the fibers will increase the amplitude. The MUAP size will increase in amplitude and duration due to increased number of muscle fibers. In myopathic processes, muscle fibers undergo degeneration. Therefore, each motor unit produces reduced force output during the muscle contraction. So, short amplitude and complete interference pattern. So, neuropathic and myopathic potentials, if you are able to differentiate at the end of the EMG, that's very good. What are the characteristics? Increased motor unit action potential, duration, and amplitude is seen. Polyphasia, decreased recruitment or picket fence pattern, recruitment ratio is increased. In myopathic, decreased duration, amplitude, polyphasia, increased recruitment ratio decreased. So I think we'll stop here at this stage and we'll continue in the next class. We have completed the EMG. So next class we'll be taking about the upper limbs and lower limbs, lumbosacral plexus and brachial plexus in detail. I think we had a good discussion about the basics of EMG, and all the students are requested to do the EMG and interpret. So we'll continue in the next class, the remaining part. Any questions? So insertional activity, spontaneous activity, MVP analysis, recruitment, we have seen. We also revised or sensitized you to some of the queries that may come in the EMG nerve conduction studies. So keep reading and we'll meet again next week. If there are no queries about this, what to read. See this, somebody asked where is this video available? It's available on the YouTube Neuro E Patsala channel. Okay then, good night.